Big welcome again, everyone. Thank you for joining us nice and early for today's meeting. We are not going to waste any time at all today. We're going to start very shortly. Big thank you to those joining us on YouTube. Please feel free to share the Zoom link with others and also the YouTube channel. And without much ado, I would be handing over to, and I'm happy to let us know that our guest speaker is in the house, Professor Nike Bello. Happy to have you, Ma. Okay. I'll be handing over to Dr. Ijoma Anaso.
Good evening, everyone. I hope you have had a nice day so far, and happy new month. Okay, so it's my privilege at this point to introduce the convener of Link Family and also the brain behind this beautiful and inspiring and paradigm-shifting program. Her name is Dr. Temitope Ayedun. Dr. Temitope Ayedun, widely known as Prison Child, is a distinguished medical practitioner, author, community leader, and advocate for the holistic well-being of people with over 2 decades of diverse experience across the public and private healthcare sectors. Her professional journey spans general medical practice, emergency medicine, critical care, medical repatriation, counseling, volunteer service, and health advocacy, reflecting a steady commitment to excellence, compassionate care, and human development. Driven by her life mission to spread love, light, and hope, Dr. Ayedun has built a reputation for positively impacting lives, both within and beyond the clinical environment. She currently serves as a general practitioner in Northeast Lincolnshire. Please don't crucify me. United Kingdom, where she has particular interest in women's health and mental health, championing patient-centered care and improved health outcomes. Beyond medicine, Prison Child is a visionary convener of the Link Family, a thriving faith-based online community established over 6 years ago. Through this platform, she has facilitated transformative conversations on relationships, parenting, blended families, fertility, and personal growth, fostering meaningful connections and empowering individuals and families across diverse communities. Her current innovative initiative explores the important subject of aging and elderly care through a 13-week educational series. We are on series 9 now, further demonstrating her commitment to addressing contemporary societal needs. She's a passionate writer and a lifelong learner. Dr. Ayedun is also the author of 2 books, The Unporridge Stories and Friendships, both of which reflect her dedication to personal development, healthy relationship, and community building. Recognized for her warmth, authenticity, and service-oriented leadership, Dr. Ayedun remains deeply committed to healing, strengthening relationships, nurturing communities, and contributing to nation building. Through her professional practice, literary works, and community engagement initiatives, she continues to inspire hope, foster meaningful change, and create lasting impact across generations. Please join me. You can go to your React button and say give our host a resounding welcome as we commence today's discussions. You're welcome, Dr. Ayedun.
Thank you very much for that introduction. It was rather long, though. Thank you. I appreciate that. So I would be sharing some slides. I'll be talking about some highlights on women's health today. like we might already know, today's session is Women's Health and Aging. And I'll be starting off with some highlights, and then I'll introduce our guest speaker, who is going to be talking mainly about the different kinds of female cancers and screening in them, just to complete the session. And she would also be available to take any questions we might have for her. So permit me to share my slides just now. Can you see my slide?
Yes.
Okay, all right, thank you. Okay. Just a minute. Sorry. Yes, I'm coming. Okay, so I'm trying to move my slides. I don't think it's moving. Let me stop sharing again and see what the issue is. Just a minute. I don't think it's moving, so I might have to do them one by one. Okay, it's moving now. All right. The Link family will still be introduced further down the line. The aims are to enlighten, inspire, empower, and give. My outline, what I'm going to be talking about today, is neurodiversity in aging women, menopause and HRT, urogenital conditions, and as I talk about them, I'll be doing my best to address the concerns that are raised from them. So, what is neurodiversity? Why is it important in aging women? And how do we manage the challenges that they bring? Some of us might already be familiar about neurodiversity, referring to people that might have special needs like autism, like ADHD, but they're a bit more than that. So neurodivergence is a blanket term for individuals whose brains process, learn, or behave differently from others. And this others is in quotes a societal standard. And that includes people with autism spectrum disorder, people with attention deficit hyperactivity disorder, known as ADHD, dyslexia, dyspraxia, and Tourette's syndrome. Individuals who process information and whose brains function in the way that society considers as a standard are known as neurotypical. 1 in 10 people are neurodivergent, and sometimes it's as high as 15% of the population. No two minds are identical, and neurodivergence is part of natural variety. Differences are treated as distinct cognitive styles, strengths, and challenges rather than broken traits that need a fix. So, why is this important in aging women? When the female hormones, estrogen and progesterone, drop, neurodivergence sometimes becomes more prominent. This is because many times these women may be high functioning and have been masking the traits since childhood. So the transition amplifies traits like executive dysfunction, sensory overload, and emotional dysregulation. This transition makes lifelong coping strategies unsustainable, leading many to seek ADHD and autism assessments in later life. This is usually done by specialists, usually our psychiatry colleagues. So the decline in estrogen reduces dopamine and serotonin efficiency, worsening focus and motivation. The sensory amplification, sounds become louder, hot flushes make everything harder to tolerate, and sensory sensitivities might be heightened. The energy required to hide the traits becomes more, and they have this feeling of being overwhelmed, and it causes mental burnout for many of them. I see many patients and they are in high-profile jobs, and once they start the conversation, they just break down into tears and they say, I just can't cope anymore. They say things like, I never used to be like this. They say they're forgetting things. That's what's the key impact, the brain fog, emotional intensity. The emotional intensity refers to the difficulty being able to manage their mood, like depression, anxiety, frustration, and disruption of their normal routines that they already have. And they say things like, they are not, I'm not an angry person, but I'm angry at everybody now. Even my husband says I'm different. My children say I'm different. People are finding it difficult to cope around me. And many times it's because of the depletion of their hormones. So managing the challenges of neurodiversity in aging women. Hormonal therapy is worth considering. Non-hormonal therapy focuses on supportive strategies to help focus, structure, and emotional resilience. So sensory well-being, they can have things like wearing dark shades, using noise cancelling headphones, things like that would help them. Reducing executive load.
Are you doing launch here?
Kindly mute yourself if you're not speaking. Thank you. So they might need to use digital planners, alarms, visual checklists, and reminders to avoid brain fog or brain overload. And they might need to schedule mandatory recovery time during busy days to prevent a total burnout. And this is absolutely necessary for them. Okay, so I'll just whiz straight to the perimenopause and the menopause, which I know is quite topical and something that a lot of people are interested in. So the perimenopause is the time just before the menopause. And within that period, the female hormones, estrogen and progesterone, are declining. And it affects fertility and it affects the periods. And so the periods sometimes become lighter, they sometimes become heavier, they sometimes become more painful, but they start changing, just the way it was when the girl started her periods, in which it was a bit hit and miss. Her period might come this month, might not come the next month, might be light, might be heavy. So that's the way it usually is in the time of the perimenopause. And the menopause is the complete stopping of the periods. Fertility is not usually possible after this time, except it is assisted. And the medical definition of the menopause is that there have been no periods for 12 months. Now, the effects of the menopause can be broadly classified into mental and emotional or physical. Now, though these hormones primarily are known to be related with the reproductive organs, they have receptors, which are tiny organs located throughout the body from the brain to the skin. And the background of period stopping is the marked decline in the ovaries producing the female hormones. Now, the mental effects of the menopause include things like mood swings, sudden feelings of irritability, like I described that some of my patients sometimes experience, anger, sadness, or anxiety. Sometimes they have some mild trouble with focus, with attention, or remembering things. Sleep problems are quite common. They might be able to start sleeping, but have difficulty staying asleep. And this is often made worse by hot flushes and drenching night sweats, which are common in the perimenopausal period. This is due to low or fluctuating hormones affecting the neurotransmitters in the brain, like was mentioned previously. Now, the physical effects of the menopause, you'll be surprised to know that there are quite many. On the heart and the blood vessels, they have an increased cardiovascular risk, long-term cardiovascular risk, which is increased once the hormones drop and blood vessel function is altered. This means they are more at risk of heart conditions after the menopause. They are more at risk of vascular dementia as well. On the bones and skin, the accelerated bone loss increases the risk of osteoporosis, and they are prone to have fractures if they fall. The skin also becomes less elastic and lose collagen. The breast, the glandular tissue decreases, is replaced by fats, and the firmness and the size reduce. The bladder and the urethra, which is where the urine comes from, it becomes thin, leading to frequent urinary tract infections and a feeling of wanting to urinate very urgently. The pelvic floor becomes weaker due to the weakening of the connective tissue. Sometimes the organs of the pelvis come out, like the uterus or the bladder, they could prolapse, and sometimes they might require surgery if it is a very bad prolapse. The vaginal walls become thinner, drier, less elastic, and prone to injury. And this makes intercourse painful. Like we already know, on the ovaries and the uterus, the ovaries shrink and stop releasing eggs. The uterus also becomes smaller and the lining thin. There's also weight gain in the menopause, and the drivers of weight gain are on this slide. First is the hormonal decline. The estrogen shifts fat storage towards the belly, so they have more belly fat. The metabolism is slower, meaning that they burn energy slower. They burn fewer calories even when they're resting, unlike when they had the full set of their hormones. Lean muscle mass reduces with age and also speeds up during the menopause. And then the disruption with sleep also affects the hormones and makes them eat more. And then, of course, because the menopause comes with increased stress, fatigue, joint pain, they don't move around as they usually do, and healthier habits might be harder to maintain. I believe this will be discussed further in our next session, which is lifestyle health in the aging. Okay, so the reported symptoms by women who are experiencing or who had experienced the menopause, like we can see the highest percentage are the hot flushes. And this sometimes affects women all the way from their 40s to their 80s and can be severely disturbing. It can make mental health worse, can make sleep worse, and it can make things difficult for them to cope with. We can also see that the night sweats are also quite top of the list there, as well as poor sleep. Okay. Right, so we see that there are quite a lot. Mood changes, weight gain, low energy, joint aches, loss of sex drive, headaches, palpitations. These are all included as part of the reported symptoms in the menopause. Okay, so this is just a pictorial representation of what I've been talking about. They could also experience thinning of the hair, dry eyes and mouth, bone loss, like we had the session with the orthopedic surgeon, and the advice is that women who are postmenopausal should have their top up of vitamin D and calcium as well. If you're not talking, please mute yourself. Thank you. Now, the solutions: hormone replacement therapy, which include gels, sprays, tablets, patches. Not one particular one might be suitable for a particular person. Like for some people, they might need to have the patches rather than the pills because the patches will not pass through the gastrointestinal tract, which is through the stomach, will not pass through the body, will go through the skin, and that is better for them. I must say that though hormone replacement therapy has made a difference in the lives of loads of women, it does not work for everybody, but is definitely worth a try. Now, non-hormonal options exist that are specific for hot flushes. Those can be used because some people just do not want to use a hormone replacement for some reasons best known to them, or because it's not clinically suitable. Some people genuinely have low mood and they've had it through their lives, and it's just made worse when they become menopausal. They might need to be on antidepressants. CBT stands for cognitive behavioral therapy, and that helps a lot of women as well. Now, lifestyle changes, reducing alcohol, reducing caffeine, that helps with the hot flushes, reducing spicy food, exercise, especially weight-bearing exercise, because that's good for the muscles and helps with burning, increasing the metabolic rates, making weight loss easier. Education for everybody, joining support groups. I must emphasize on the education, because the more people know about it, the more we're able to support our women through this stage and period of their lives. So their spouses need to know about this so that they can support them. Their children need to know about this so that they can support them. They need to be supported in the workplace. So they might need to have fans around, they might need to have air conditioners. You probably already see them going around with fans anyway, because they just cannot cope with the unbearable heat. And I remember when I was in training, I just used to remember lots of women that would say, oh, they have internal heat, they have internal heat. And I didn't really understand what it was until I had a few myself. So hot flush is a really serious concern for menopausal women. Okay, so I'm going to go straight to urogenital conditions. We're trying to whiz through so that we have enough time for questions. So you can see top of the list, we have lichen sclerosis and we have lichen planus. They are actually skin conditions. So I'll talk about them shortly, but not just yet. Right now, I'll just talk about the genitourinary syndrome of menopause, which is referred to as GSM. And so, and then also the urogenital conditions also include urinary incontinence, recurrent urinary tract infections. These chronic changes, those three, the GSM, the urinary incontinence, and the recurrent urinary tract infections, they affect over half of postmenopausal women, but often go underreported and therefore untreated, which is very sad, meaning that these women have to bear the burden of all of this happening to them. I don't know whether any of the link officers could just go into the chat and put the link for the YouTube channel, because I am told that some people are having difficulty connecting on the Zoom. So please put the link for the YouTube channel, the live stream to them so that they can join us from there. Okay. So common changes, common symptoms, I meant to say: vaginal changes, vaginal dryness, itching, burning, thinning tissues, which obviously then make intercourse painful, which is clinically known as dyspareunia. The urinary tract issues include urinary frequency, meaning they always want to pee. They always have the sensation that they want to urinate. And then they go really frequently. And when they urinate, it's painful. Sometimes when there's any stress, like a cough or a sneeze or a laugh, they leak urine. And sometimes they leak urine just on their way to pass urine in the toilet. There's a higher risk of recurrent urinary tract infections due to a shift in vaginal pH and the loss of protective bacteria. Generally, women are at higher risk of urinary tract infections than men because they have a shorter urinary tract, which is about 5 centimeters compared to 25 centimeters in most men. However, they now have a higher risk of having infections in menopause due to these reasons. Now, the management. non-hormonal relief, like the regular use of vaginal moisturizers, lubricants for dryness and sexual discomfort. Local hormone therapy is very useful for a lot of women, low-dose estrogen. Sometimes creams, tablets, or rings can be used, and it usually helps them. Many times they just start with use it nightly for about 4 weeks. After that, they start using it twice a week and they can maintain that. Of course, they have to be told how to use it and to look out for any signs that might cause worry with the local hormone therapy. Physical support, pelvic floor exercise, pelvic floor therapy does improve function and helps to control the bladder symptoms as well. Of course, for women that have a prolapse, they might need surgery, and that might help their symptoms as well. Some people decide not to take the oral or patches of the HRT, hormone replacement therapy, and decide to just use the local hormone therapy for the vaginal region. So I'm coming back to the painful genital conditions that I mentioned earlier. So there's vulvar lichen planus. So both of them are chronic inflammatory skin conditions. The lichen planus is characterized by red, sore, raw patches, which causes intense itching, potential scarring, and can narrow the opening of the vagina. It frequently affects women in the menopause and can cause painful intercourse and urination. The treatment, high-potency steroids, warm water washes, barrier ointments, like petroleum jelly, loose soft cotton underwear, and avoiding tight clothing. Lichen sclerosis, as I said, is also chronic. Both of them are suggested to be autoimmune conditions. That also causes intense itching, soreness, white patches, unlike the red patches of lichen planus, and it also causes scarring. It can cause skin tears with minor trauma, scarring and narrowing of the vagina, and it can also cause fusion of the labia, which are the two lips that cover the vagina. It is prevalent in postmenopausal women and children under 10. Friction, urine contact, or injury can trigger a flare, and this is known in medical parlance as Koebner's phenomenon. It's also treated with potent steroids, emollients, which can be used instead of the usual soap, and barrier ointments like petroleum jelly. Self-monitoring with the mirror is necessary. It's actually important for them to see a gynecologist who is a specialist in women affairs, because sometimes they do need a biopsy to exclude vulval cancer, because it can become a cancer, especially when they have non-healing sores. So this, I think, is my last slide. I'm very close to the end. I'll just be talking about low libido. So this is primarily caused by hormonal changes, physical discomforts, and psychological factors. So the hormonal shifts, we know that the lower estrogen, there's less lubrication in the pelvic area due to the low hormones. And we also know that testosterone, which we usually consider to be the male hormone, but is actually present in both males and females, is also reduced in aging women, and that also causes reduced desire. So those are the hormonal shifts in aging women. And then the physical symptoms, the vaginal atrophy, which means shrinking of the tissues of the vagina, genitourinary syndrome of menopause, which causes pain avoidance. Nobody wants anything that causes pain. So if they try intimacy and it causes pain, then they begin to avoid it. The fatigue and pain that comes from the joint aches, the pain drains energy for intimacy. Emotional and lifestyle factors like mental health, like their body image, because it's changing, feelings of low mood, anxiety, relationship dynamics like poor communication, like poor health of a partner, and things like that, as well as medications that affect sex drive, like some antihypertensives and some antidepressants, can also be among the factors that can cause low libido. And the treatment would depend on the cause. And yes, with the right support, and information, every woman can age gracefully. Thank you for your kind attention. And that's it for me. Thank you all for listening. I hope I was not too fast. And please get your questions ready. We will take them at the end of this session. And I would hand over to Dr. Ijoma Anaso, who would be talking very briefly about the Link family. Over to you, Dr. IJ.
Thank you so much, Praising Child. I have my questions ready, and it's very insightful because you know, sometimes you just wonder, in fact, I think men should listen to this even more than the women, because I've heard discussions around people saying that their wives are deliberately are running away from intimacy. But let me not overreach. It's my opportunity to talk about the Link family. When I was introducing the Praising Child, we had talked about the fact that she was the convener of the Link family. So let me briefly talk about Link family. The Link family is an amazing online group open to people from 16 and above. So we have teenagers, we have people in their 70s. As we were beginning, I heard Mommy talking about her 70th birthday. Congratulations in advance, Mommy. And the group is aimed at healing and building healthy and healthier relationships. We help each other in gaining insight into our relationships, marriages, parenting, and life, and encouraging ourselves to healing and wholeness in every aspect of life. It comprises of people, young people, single people, divorced, widowed, married people, older adults from all over the world. Praising Child is in the UK. I know a couple of people in other parts of the world, in the US. Unfortunately, one of them is not here. So everyone from every tribe, nation, race, and religion is welcome. We have Muslims in our midst, but we are guided by biblical principles. I've personally found the Link family to be inspiring and a source of comfort. We have had previous series on relationship, parenting, blended families, fertility, and now we have this series on aging and the elderly. These are available on the YouTube channels. My friend Olanike has posted the YouTube channel, so we can go to the YouTube channel to see the previous editions of the program of the Linked family. So please, we encourage you to subscribe to the Linked family page, because if you do so, as soon as a program is going on, you'll be notified immediately. My friend like Nike may take this opportunity to repost the YouTube channel. Our meetings are usually weekly, especially on Friday on Zoom and YouTube, and they are usually live. The channel is called Temitope Praising Child, with a few annual face-to-face meetings. I know we had one in London recently, and we've had one in Ibadan. I think we had one in Ibadan last year. So the Linked family started in 2020 by Dr. Temitope Ayedu. That's a Praising Child who is a convener, and we would encourage you to join us, and you're welcome. We'll learn from you, and we will be learning from each other. Please, we encourage you to click on the chat. I'm going to post the chat on the channel now for
Sister Nika is posting it.
Oh, fantastic. And if you have any questions or comments, put them in the chat or raise your hands during the Q&A session. We'll be grateful if you could turn on your camera. At the end of the session, we would like to take a group picture. We would like you to turn on your camera just for a few minutes. Thank you very much. I'd like to return the mic back to Praising Child.
Thank you very much, Dr. IJ. It's awesome. Okay, so we are going to be having our guest speaker now. And I will just put her on the screen while I introduce her. Can we have your camera on, Ma? Thank you, Ma. Okay. Yes, Professor Nike Bello graduated from the College of Medicine, University of Ibadan in 1999. She is a professor of obstetrics and gynecology at the University of Ibadan and a consultant obstetrician and gynecologist at the University College Hospital, Ibadan, my alma mater, I might add, training medical students and resident doctors since 2006. She actually taught me as well when I was in medical school. Her main interests are infertility treatment and post-delivery bleeding, and she has collaborated on several projects in these areas with the World Health Organization and the London School of Hygiene and Tropical Medicine Clinical Trials Unit. She is the country director of the London School of Tropical Hygiene, London School of Hygiene and Tropical Medicines Research collaboration with Nigeria, under which she is currently coordinating clinical trials in 10 Nigerian hospitals. She sits on NAFDAC's Clinical Trials Advisory Committee. She has published 93 peer-reviewed articles in academic journals and 3 book chapters. She is nearly always working, but when she is not, she spends time with her family and reads fiction and biographies. Join me as I welcome Professor Nike Bello. Thank you, Ma, for joining us.
Thank you, Temitope. Nice to be here, everyone. Okay, that wasn't agreed upon by you. I gave you 2 lines by your top. But thank you. Okay, I will get right into it. I could change this to slideshow, but sometimes I just prefer to use this outline method because, yeah, okay, because the slideshow sometimes hangs like yours decided to earlier, but the slideshow seems to be working, so we're good. All right, a good afternoon, evening to everyone. Good morning if you're in Asia, but
Yeah.
I doubt it. But yeah, Temitope wants me to talk about 5 cancers in 20 minutes. So we're not really going to teach cancer. I'm assuming that I'm talking to people that just want to know how to protect themselves and not want to get an erudite scholarship in the treatment of cancer in women. So I'll just highlight specifically on the things that I would want to know if I were not a doctor to protect my own health and advocate for myself. So we'll be talking about these 5 body parts. I put a picture to cover the female reproductive systems. I didn't put a picture of the breast because, well, every woman knows what breasts are. We've all got them. But then these organs, because they are internal, we don't necessarily know about them all the time. So I think my cursor is visible. Yeah, and it's labeled too. So if you start here from the vagina, the vulva, where everyone is familiar with, the vagina is a tubular structure that leads up to the uterus. At the neck of the uterus is this thing called the cervix, and it's one of the cancers we're talking about today. Then the uterus. Then abutting the uterus on either side are little organs called the ovaries that produce the eggs that we make babies with, and also produce all the hormones that mediate our cells, not just our reproductive life, our whole cells. Like Dr. Aydon has pointed out, when estrogen leaves, that's the hormone that's being produced by this ovary, it affects everything. It's not just about making babies. It affects your mood, it affects the way your pelvic floor behaves, it affects the way your entire body behaves. Your fat redistributes, goes to your abdomen, your breasts become flat, everything just, becomes sad sometimes. So it does a whole lot more than make babies. And I'll also be talking about the bladder, not because it's a reproductive cancer, but just to say, just a pointer towards what concerns women as they age. So let's start with breast. We're starting with the breast because it's the most common cancer in women. Now, the most common cancers in women are not necessarily reproductive cancers, but the breast is the highest, followed by probably the lungs and the colon, that's part of the guts, which are common to both men and women. But breast first. Now, breast cancer has had an amazing amount of research and has had an amazing amount of strides in progression, in how we treat and how you can be a breast cancer survivor. There are many. But having said that, it's still a formidable, a daunting opponent. And when it happens, there is so much that goes into its care and the support that is needed that it's one of those things that are best prevented when you can. I say when you can, because sometimes, despite people's best efforts, the best that you get is early detection, and cancer is cancer. If early detection means that you have a better chance at it, but it still does mean that you're already treating a cancer. So traditionally, over time, you must have been told at some point in your life that at one point in the month, you should do a circumferential palpation around your breast. Usually said that you should choose just after your period, where your hormone levels are somewhat low before they start building up to the next period. There have been different recommendations. Do it lying down so that you can have your chest wall and the bed you're lying on as a support to keep it flat, or do it in the shower when your hands are somewhat lubricated and the breast itself, and you can feel it better. But over time, evidence has shown that it's not necessarily helpful. Now, it doesn't hurt to do it, but for some people, it gives unnecessary agitation when they find benign lumps and then they get bothered about it. But frankly, personally, even the medical knowledge is not behind it, I don't see how it can be a bad thing. Now, it doesn't mean I do it because I'm lazy and I forget, but it also means, but I think that if you can get over yourself and not be worried about what has been evaluated and you have been told is benign, I don't see how it can be a bad thing if you can detect early. Now, as we age, not everyone has periods anymore. So you don't even have that. Sorry, everybody eventually stops having periods, not everybody. Eventually, everybody becomes menopausal. So we might not even all have that monthly reminder of a period to tell us to check our breasts. But at the annual exam, most women will still get it checked. But what is best? What is recommended is a screening test. Now, the screening test is the mammogram. It's a specialized X-ray in which they compress your breasts between two surfaces that take an X-ray of the tissue. It is not a painful exam, and I say that with all responsibility as a gynecologist who unfortunately sometimes causes pain to women. Not that I'd like to, but it's part of my day job. And as a woman too, they cause pain to me too. I mean, all those uncomfortable things they do. People have a lot of worries about mammogram because, well, it is uncomfortable when two surfaces are pressed in your flesh together, but it's not pain and it's essential. Now, in places where you pay out of pocket or where it's done privately, you get it done anytime from the age of 40, and it's recommended that you do it annually. But in places where there are programs that give it to you for free as part of your healthcare, they're usually a little more stringent with it. Most places will say 50 years now, partly because at 40, your breast tissue is more dense and is less likely to be visible through an X-ray, and also because when you look at the opportunity cost, the amount that you detect is not as many as you detect when people are older. So if we're praying for everyone to do it, let's do it when, we think it's most effective. But if you're paying out of pocket, you can do it from 40. And it's recommended every 2 years where it's being paid for, but if you're paying out of pocket again, you can get it done every year. So I'll say every 1 to 2 years until some countries stop at 70, some say you can keep on having it until 80. And if by then you don't have a mass, the risk that it will occur in your later years are much less likely. So they can stop at that point. And moving on from breast cancer, I'll go to ovarian cancer. Now, ovarian cancer, the main problem with the screening for ovarian cancer is that it's not a visible organ. It's not a nearby organ. It's not an organ you can touch like the breast or like the cervix or like, other places. It's an internal organ that you cannot assess except to use imaging of some sort. So, and the early signs are also non-specific. When women, the first complaints they have are non-specific ones like indigestion or abdominal pain or having gas or having acid reflux or bloating, things that you'll think is a GI symptom and you'll give them an antacid for. And often by the time you can assess it, there has been significant growth because there's no particular reliable screening test for it, unlike cervical cancer that I'll talk about in a minute. But for women that have risk factors, right, there's targeted screening that's recommended, which is a bit heavy if you offer it to everyone. Now, these risk factors are people that have had few or no babies, or any other thing that gives you a long menstrual life, so to speak. You started your period early, you entered menopause late, you did not stop ovulation in between by having babies and breastfeeding. So it's not really the babies, so to speak, that are protective. It is the fact that when you are pregnant, you are not ovulating. When you are breastfeeding, the chances that you're also not ovulating. So those reasons give time for ovulation to occur, and each of them acts somewhat like an insult on your ovary. And women that have not used contraception for the same reason, they're ovulating continuously. And the women that are genetically disposed, it runs in families too. So for those, they do the risk factors that they assess things like a pelvic exam, as in going for vaginal exams. Again, not painful, but can be uncomfortable when fingers go into you and doctors poke things, and we say annoying things, a little like the dentist. I'm not sure if there are any dentists listening to me, but we say things that it's not pain, it's pressure. That's what dentists say too. When it's paining you, they'll be telling you that it's pressure. We also kind of do that too. I'm apologizing on all our behalf. But we do it because there's no neater way to assess this organ that's inside. Now, we also do things like an ultrasound. So the two of them combined together gives more, what's the word now? Makes the exam more sensitive. You palpate, you feel, and then you do a scan. There are people that advocate that skip the palpating, just do a scan. You see if there's a lesion on the ovary. And that's true too. But when you're making guidelines, you make it for a wide range of people. It's not everyone that has ready access to an ultrasound. But for everyone on this call, I think you'll have ready access to an ultrasound. I mean, you have internet, so why not? And then there's an antigen that frequently causes this cancer that can be screened for. Again, it's not for everyone. And for those that have those genetic mutations, they're called the commonest ones. The most common ones are something called BRCA1 or BRCA1 and 2. For those people that have that strong family history, it's best they all go for genetic screening. And then you cannot decide to do something radical, like just decide to take out your ovaries before they cause trouble. That will save you from ovarian cancer. It will also save you from breast cancer, because breast cancer, for the most part, comes from the same hormone that causes the ovarian cancer. So what's the short answer about ovarian cancer? There is no one screening for it. When you have non-specific symptoms that go on and on, a doctor can take an index of suspicion and check further for these things. But if you have a family history, they're definitely checking for these things annually from when you're 40 or so, or except you agree to just, take out those organs and not be at risk again. Endometrial cancer, not much to say here, but it's about the fourth commonest cancer. So it's important to talk about. It's mostly in older women. But as we all know intuitively, whether we're doctors or not, we're all knowing people that are getting cancer younger and younger. And this, like all the other cancers that are affecting women at younger ages, but basically it's mostly a disease of old age. We'll say from the 6th to the 7th decade, that's in your 60s and 70s. And that's one thing that makes... Okay. That's one thing that makes screening for this cancer relatively easier, because women in that age group have stopped menstruating, and the main symptom of this cancer is abnormal bleeding. Bleeding that's not menstrual, that's not cyclical, that just comes by itself. Now, it can happen in a younger woman, and what will make you suspect is you have intermenstrual bleeding that's not your menses, that just keeps coming. And then you'll have an investigation that will check for it. But in the older women, any bleeding after your periods have completely stopped is abnormal. It could be something slight, like you had sex and because the lining there was too thin because you're older, it bruised you and you had that. As in the tissue there is atrophic, as in old, thinner, less resilient to acrobatic sex, for instance. And if you're active enough to have that, you can have some bleeding. And easily by doing a pelvic exam, we'll see the bruising and know that that's where it's from. But it's worth evaluating every time. And the reason why we do that is that if you don't and you wait, it will take long, but it will have grown much more advanced before we get to that point. Now, a simple examination for it is an ultrasound. An ultrasound can easily tell if the lining of the uterus is thicker than it usually is. So in that situation, if they now find that kind of thickness, there's an in-office biopsy that is taken. I've gotten ahead of myself to my next line. An in-office biopsy that's taken. It's not, biopsy usually means to cut out tissue. This is not a big cuts and takeouts. No, it's like, let's call it like a mini D&C. No D involved, no dilatation involved, just a tiny flexible little catheter that's put in and then under suction pressure, just suck out some of it. And what it does is that it sucks the cells in the lining of the uterus, and they can be looked at under a microscope, and it can be determined if these are just normal cells, old atrophic cells for older women, and that's why there's that bleeding, or if there's a lesion. So that's all I'll say about uterine cancer. I think what I have to say about the most cancer I have the most to say about is cervical cancer. And why is that? Cervical cancer, as devastating as it is, it's one of our wins in gynecology because it is the cancer in which, one of the few cancers in which we have identified one cause. Over the decades, at first, there was no cause known, but it was simply apparent that this cancer is associated with sex. Women that had more babies were more likely to have it. Women that were commercial sex workers were more likely to have it. Distinctly, nuns, people that had taken vows of celibacy, were not suffering it. So for long, for like a century or so, they had known that this has, more than a century actually, that this has something to do with sex. And they tried to identify all kind of sex factors. Like, is it the semen itself? Is it this STI? Is it that STI? But eventually, human papillomavirus was identified and shown to be the cause. So the first level of prevention, like all sexually transmitted infection, will be anything that will prevent you from getting an infection from sex. Human papillomavirus is a normal, it lives on our skin. We call it commensals, as in a commensal that just lives on you and causes no problems. But when it gets to some certain tissues, like the cervix, like the penis, the anal region, even the throat, it can behave differently and cause a cancer. Now, I'm using the word can. It doesn't mean that everybody that has human papillomavirus gets a cancer, but people that are predisposed to can get the cancer. So the primary prevention with let's prevent the spread of human papillomavirus. And so there's an ABC that we say for preventing sexually transmitted infections, and that applies to this as well. Abstain in the first instance instead of having casual sex. When it's time to have sex, when you're ready to have sex, it should be consensual, faithful sex, mutually faithful sex. And the C part is condom, meaning that protects, that use a barrier protection. Now, that's not always possible. There are times that you will have sex that is not protected, right? But at least this limits the herd spread of an infection if the only times you do this without protection is with a mutually faithful partner. And then HPV vaccine arrived in 2006. That's when it was first licensed in the US, and then it went around the world. it's given, the program starts to give it like the age of 9. And that's because you're trying to give it at a time that a child's immunity is developed enough for it to form enough memory to be useful for you in your adult life. That's why it's not given at birth, the way we give, polio and HPV and, I'm sorry, and hepatitis and the other viruses. But you want to give it before sexual debut, that if HPV has not been transmitted, it works better. So that's why it said most programs are for like age 9 to 11, but it's licensed up till age 26, at least for catch up for the people that were already older than that before the program started. Further research has shown that it's effective up till the age of 45, but it's more effective if you don't have HPV. So it's often recommended that you can just get an HPV test. And if it shows you don't have HPV, you can get it. Anything older than 45, there's no evidence for it. So, and I don't know any international body that recommends it. So there is probably no use to you doing it. But the main level of prevention that most of us were already in before all these nice things like HPV came up, for those of us that were too old when HPV arrived, HPV vaccine arrived, secondary level prevention is what everyone has always done. The Pap smear, the Papa Nicolau smear, I think, was determined, I think, if I'm not mistaken, like the 1940s. It's a really old test. And the main advantage is because the cervix is accessible. If I do a pelvic exam, if I splay a woman's legs in that horrible, horrible way that's we lie down in that position with your legs hanging out like that, it's not a nice position. It's a degrading position, but it's an excellent position because we get to see everything we're meant to see. And that's what I tell myself when I'm in that position, that, yeah, this is necessary for me, even though I look hapless and helpless and vulnerable. But I digress. In that position, you can see the cervix straight on, right? When you pass that instrument I'm showing in that picture there, the speculum. And when you pass that, you can now use like a wooden stick or a brush, like I've shown in the picture below, which is what is more commonly used nowadays. It's more effective. The brush is more effective than the wooden stick. So just scrape on it. You're not cutting anything, just scrape, because it is tissue that rapidly sheds cells. It's accessible, so it's so easy for you to screen. And that's the reason why cancer of the cervix, like I said, is one of the wins, because it went from being a very common cancer to a cancer that is so preventable. So if from the age of 25, evidence changed until 25. At first, it was like within a year of you having sex, until they realized that no, teenagers having sex were not really at risk of the cancer then. And then it changed to 21, but presently it's at 25. That if at the age of 25, you have that pap test every 3 years and it remains normal, you can stop at 65 and not expect to have cervical cancer. Not that cervical cancer cannot happen in later years, but it's a really slow-growing cancer. So if you see an abnormality on a pap test, from when you see the first abnormality of an intraepithelial cancer, which means a cancer that's just within the lining of the cervix, it has not gone far at all, till it becoming a full-blown invasive cancer, 10 to 15 years at least would pass. So if you're doing this test every 3 years, there's no missing of it. And then even better, we now have an HPV test that it's not just checking the cells to see whether abnormality has started. It's actually checking the cells to see if they have been infiltrated with HPV. And if HPV are in the cells, then you know this person's at risk, and you can, you're already looking for progression. But if HPV remains not there, then you know that she doesn't even have the risk that will cause this. And even better still, in many places, HPV tests are being offered at home. Did I say many places? Not really. I know the US has rolled it out. Some provinces in Canada have taken it up. I don't believe the UK is doing them yet. Tell me, are they self-tests at home? I don't believe so. No, it's not. Yeah. So that's just basically North America. And yeah, if you're in Nigeria, no, we don't even have routine HPV tests in Nigeria. What we still have is the pap smear that you do every 3 years. But these HPV tests have seen to be so effective that it's said that it's every 5 years that you need to get it. So the follow-up, if there is an abnormality, then you don't do it in 3 years' time. They'll tell you to come back in 6 months, or we'll treat it. Maybe just burn off the area that is abnormal, or freeze it, or even cut it off, and then you just continue your screening. But all this will be precancerous changes, so this is preventing the cancer entirely, unlike the others that you are actually trying to detect a cancer early. So that's why this is more effective. So just one more slide to talk about bladder screening. There is no routine screening, and bladder cancer does not necessarily happen to women more than men. The notable thing about women is that because the middle age has changes all in that, nether region that includes the bladder, sometimes it's masked. For instance, urine tract infections can be recurrent in women of middle age. The lining of the bladder is thinner, sex or anything can cause it more frequently, or the fact that your bladder just really cannot hold urine long, and if you do, the urine could form like a medium for bacteria to grow in. So you can have urine tract infections. But if you keep on having symptoms of urine tract infection, wanting to pee so often, burning while peeing, and consistently you're evaluated and no infection is found, and they're just telling you that, okay, drink cranberry juice, it'll help to acidify, or pee right after sex, or pee frequently, don't allow the pee to develop there. At that point, you should evaluate for bladder cancer as well. Okay, those were bladder screening. Sorry, I meant to write bladder cancer screening. And if for any reason you find blood in your urine, even if it's a one-off and it stops, it's worthwhile evaluating it. It could be something innocuous, like hookworm, even though I don't know why people that don't live, if you're not maybe on an expedition in the bush, I don't really see why you should have hookworm, as in if you're not eating off the road, but it's a possibility, right? It could be something as simple as hookworm, and that could be treated. It could be something as simple as bruising. I keep on bringing up sex because, yes, for the middle-aged women that have sex, they do have these issues. I know not all middle-aged women are able to have sex for different reasons, but when they do, we still keep on getting these things. Okay, I'm sure I've overshot the time that I said I would be speaking. I told Timmy that adults who are not school children do not listen for more than 30 minutes at a go. So anything longer than that, I would lose the audience. So if I've spoken too much, forgive me. It's Timmy's fault. She told me to talk about 5 cancers in 20 minutes. So,
Thank
okay, thank you for
you,
listening.
Professor Nike.
Mhm.
She's such a delightful speaker. All right, now it's time for
Thank you.
questions. Let's give her a round of
Thank you.
applause.
Thank you, everyone.
So much fun. So it's time for questions. I hope we have loads of questions now that we have both finished speaking, and I would like you to direct them all to her.
Oh, wow. Thank you.
Okay.
No
Yes.
good deed goes unpunished.
Yes, ma'am. Okay, yeah, let's get the questions coming. I think someone put something in the chat. Let me see. Okay, someone's put one question. Can diet help with depleting hormones in aging women? And the person,
Okay.
Yes, please.
Yeah, the main hormone that's causing all this trouble, that has left the building and is causing all the trouble, is estrogen. Now, estrogen is produced by your ovaries, but there are foods that have estrogens. They're called phytoestrogens. They're like plant estrogen. They might not do the whole thing, but they can help. Now, there are these seeds for flax seeds that some people swear by flax seeds, some people swear by evening primrose oil. In fact, I think evening primrose oil has scientific evidence. There are published papers that says it's helpful. There's I've never said this word out loud though. Ashwagandha. Is that how to say it?
Ashwagandha, yeah.
Like I said, I've never said it out loud. I've only ever read it. But there are many menopausal providers that swear by it. These are all herbs and, natural things. Swear by them that they improve that. This may help, and I'm all for using natural help, right? But I'll also say that if you're in perimenopausal trouble, that using estrogen is a good thing. We've not always said this because, when this large trial that was called the Women Health Initiative came out, everybody became scared to use it because the way they did the statistics, it made it sound like as if giving estrogen made things worse. But they didn't stratify to women that were just undergoing the transition, women in their 40s and 50s, from women in their 60s and 70s that were already at risk of those things, and that giving estrogen was probably not a good idea at that time. But other sub-analyses over the years have stratified and have shown that no, HRT is a good thing after all. So, oh yeah, someone says that ashwagandha does wonders. See, like I said, and I've read about it. I've just not tried giving it to patients or tried using it for my own menopausal symptom. But I see, I see many advocates swear at its validity. So yeah, I'm told it improves sleep, as in that horrible sleep of midlife in which heat wakes you up and then your bladder wakes you up and night sweat wakes you up and then you leave. Oops, my battery's about to die. Give me a second. Oh,
Okay.
wow. Sorry, I wasn't plugging it. Yeah. And then everything wakes you up and then it's just generally cannot sleep and then you're crabby all day. I'm told it helps with that. I'm told it helps with, I'm sorry, I keep talking about sex. It's fertility I treat too, not really sex. So I don't know why I keep talking about sex, but I'm told it helps with sex as well.
Okay.
And I've not seen, the only reason why I'm not definitely saying it is that I'm a researcher. I believe in science, and I've not seen anyone publish about it that they did some. Okay, oh, says the husband should get ashwagandha too, and we should thank her later. So both husband and wife. So that'll be a
Um,
bit like that date thing. That's date and what's that thing that
Sesame seed,
nothing that our northern sisters have told us works wonders.
walnuts, sesame,
Tiger nuts,
tiger nuts.
tiger nuts.
Okay.
Yes. They said give the woman and give the man tiger nuts. But
What are your thoughts about soy proteins? Soy.
yeah. Again, I work with evidence. I don't know any evidence about it. But here's the thing, working out from basic principles, plants, estrogens are definitely suitable if they're available, as in any plants that has estrogen in them. Now, soy is not, I don't think soy proposes to have estrogen. It's just supposed to be like a protein substitute for the red meat that many authorities say worsen menopausal symptoms. Again, because I read a lot and I read around what people do and I do a lot of gbegbono, I know that is said. But frankly, I have not seen high-level evidence in science that says that those things are a problem. If you work it out from basic principles, that we metabolize less when we're middle-aged, that the thing we used to be able to eat and metabolize, right now it just sits in us and we're losing protein and we're gaining fats. I can imagine how soy would be so much better than red meat. It produces all the protein without the cholesterol, without the fats, without, the other issues. But I'm being wary about giving it a definite stamp because I've not seen any evidence.
Okay. I know.
HRT in older women. Okay, you want
Okay.
to say something about soy?
Yes, I just wanted to
Okay.
say that the Mediterranean diet or similar is also advocated in
Yes.
Proposal Life that is quite useful. Of course, cutting down on caffeine and alcohol and spicy food also helps with the hot flushes. I think there
Yes,
was a
yes.
question about, I
And the
know,
Mediterranean diet, I believe did you speak about it earlier? Yes, the Mediterranean diet is advocated, yeah.
yes. So there's a question for you. I know we have listened to cancers of women. Please, can you also talk about benign growths like fibroids, though I realize it's a mid-age issue. So I guess the question here is what happens to fibroids post-menopause?
Fibroids is fed by this hormone of interest estrogen. When estrogen diminishes, fibroids start to shrink. Now, it may not be drastic, as in you might not see that fibroids will now suddenly disappear. No, not necessarily. But because they are not being supported or growing, then the symptoms diminish. Now, most women's symptoms are painful menses and heavy menses. So once you stop having periods, that goes away. Now, if you had an unsightly mass that everybody is asking you that you're pregnant, the mass won't disappear that quick. In fact, in some, it might never go away, it might just stay static, but in some, it starts to shrink. But fibroids basically diminish at the menopause. And if at all they're still there, they stop causing symptoms for the most part.
Okay, so there's a question. What are your thoughts about HRT in older women in their 70s?
I think the question will be what would it be before? Because HRT is what the teaching has been hitherto has been use it for the minimum time that you need to, as in if you need to stop, I mean, if that's not the word, if the need for it surpasses, as in you can win it off after hot flashes have ended and other things have ended. But there's some women that generally just use it indefinitely. If we're starting it in the 70s, I'll have to ask why. Because it's not usual that you'll find a 70-year-old woman that's having new onsets of vasomotor disturbances, like those night sweats and hot flashes and, awakenings and those things. So you'll wonder why. If it's for a limited thing, like bladder control, an estrogen cream that is used down there is helpful for that. If it is for, an atrophic vagina and is getting more painful, sometimes it's a lubricant that's no, not lubricants. At that age, a lubricant is not enough. A moisturizer, a vaginal moisturizer that actually moisturizes it, or a cream, an estrogen cream. I would say I will treat each one on a case-by-case basis. I'll review the evidence for that situation and decide if it's worthwhile starting HRT in the 70s. But my first inclination will be to start it at perimenopause, not that late. And I would have hoped to have weaned it out by the 70s.
Of course, the current literature supports that you can take HRT as long as you need to take it.
As long as you need to,
as long as there are no contraindications, which is very different from what was being said before, just because of the small risk of cancers and things like that. Well, of course, patients need to know what to look out for. They have to be reviewed regularly, and they can be encouraged to stop, but at the same time, they don't have to, like they were before. And unfortunately, not many medical people are informed about this. So some people still say you can't have it. I was in that group before I got more education.
Would you start it for someone in her 70s?
No, I wouldn't.
To answer that question, would you?
It's not likely. I'll probably ask for advice from a gynecologist. Of course, if it's for bothersome flushes, I'll take advice from a gynecologist. But of course, some people do have bothersome flushes up to their 70s and 80s. So if it's something really affects
which I said
their
on a
lives,
case, I'll take it on a case-by-case basis. It's not likely that those things start then, but they can. You're correct.
Yeah,
they can.
especially because things have changed and they weren't offered before. So someone has a question here. I think it's quite personal. Person says, person 64 had a hysterectomy in early 40s. Gynecologist said, do not take HRT. So I got used to menopause. He also said you don't need to do a pap smear because they took out the cervix. And other gynecologists advised to do the pap smears. So what do you advise for my education?
Okay, good question. And this is really typical. I mean, you had your hysterectomy 20 years ago, and your gynecologist wasn't wrong. 20 years ago, most of us would have said the same. In fact, Um, Most of us would have also, many people would have also done a removed your ovaries at that time. I'm not sure if your ovaries were taken out, but they must have been for HRT to have been a discussion. That means your ovaries were taken out. Now, I don't believe I can remove a 42-year-old's ovary for benign disease. I do not see any disease on the ovary, but that I'm taking out uterus for maybe fibroids, and I'll just take it as added bonus to save you surgery in the future. No, no, no. None of us are doing that anymore. We recognize that the longer you can have your own estrogen serving you, the better.
The
And
person has
but
responded that ovaries are still in.
are still in. Okay, so that's why
Yes.
you didn't need HRT. HRT is a function of whether you have ovaries or not. It's the ovaries that produce estrogen. The uterus in itself is not the issue. It's the fact that ovaries are usually removed with the uterus. So that's why you didn't need HRT. So you must have undergone natural menopause in within those 20 years, but it might be difficult to pinpoint when it was since you did not have the menstrual stoppage to guide you. So what will determine whether you need HRT now is what symptoms you have now. HRT is not routine. It's not something that's a rite of passage that every woman must have. It's something to make the perimenopause easier. If at 64 you have gone past all the yes, periods will stop. Your uterus causes periods. So periods will stop. I see she's written, immediately I had hysterectomy, period stopped. Your period is bleeding from the lining of your womb. So as soon as you remove your uterus, periods stop. But it doesn't mean you're menopausal. Periods have stopped, but your ovary is still functioning. So every month you still have ovulation, and every day your ovaries will still produce estradiol, estrogen, which is the hormone that, keeps us going, so to speak, as reproductive age women. So somewhere in between, let's say maybe when you were like 50, thereabouts, because that's 51 or so is the world's average for the age, you might have undergone menopause. You may have noticed it at that time because they're having symptoms of, you know, these hot flashes, these sweats, changes in your mood, your sleep, or it might have gone by unnoticed. I don't know which one happened. But it's your current symptoms now that will determine whether at the age of 64 that you need it. So you have a lot of symptoms, but you manage them. So a new discussion now with someone that's interested in menopause, like a family physician like Dr. Ayedu, because like she's pointed out, we were not taught too much about it in school. So most people don't know so much. The people that belong to the menopause societies keep themselves abreast with information, and then they now certify themselves as menopause, providers, perimenopausal healthcare providers. So you need to talk to someone, and you and your provider will determine your symptoms together, your current state, and decide whether at the age of 64 you have symptoms that will warrant that. But it's a suitable thing to use. That's the answer if it's needed. I just think that you might be so removed from menopause that the symptoms might have resolved, but if not, yeah, have a discussion.
I think someone also had a question that she's heard about some women who have hormone treatment for aesthetic purposes.
That's new.
Okay, sorry,
I've
before
not
you go to that
heard
question,
of that.
the last question has asked about what about the cervix? Usually when the womb is
Oh,
removed,
yeah.
they remove the cervix with it, wouldn't they?
Yes, yes. That's why they told her that she shouldn't have
Yeah,
pap smear. But there's some authorities that say you should do
yeah.
vault smear. Vault smear means that roof of the vagina that we left, just still swab it for what it's worth in case there were tissues there. Is that great science? I don't know. Because if you took out the entire cervix, you have taken out that transformation zone that um, um, the cervical cells can come from. Maybe it is to cover our backs. Maybe it is for a patient not to come and say, but you guys said you are taking it all out, and that what's the harm in doing something every 3 years? But frankly, if you've taken it out, it should be fine. But I cannot deny that there are texts that say you should do vault smears. Now that HPV test is out, I can just say that, well, if it's a subtotal, someone is contributing that it could have been a subtotal hysterectomy. If I'm a surgeon, I did a subtotal, you'll never tell a patient you don't need smears. She said her surgeon told her that you don't need pap smears anymore. So that means that the surgeon knows that he took out everything. Out if but then the truth is that the recommendation ends for the age of 65 around where you are. So if you need a once and for all, if you've not done any smears at all since that time, I need a once and for all assurance. I'll say do one, or better still, an HPV test, and then you can rest. But if you've done any that have been fine, then really you're about the age that we stop screening. So yeah, if you've been up to date with your screenings.
Okay. Someone has talked about HRT for aesthetic purposes. I'm not aware of it. Like, it's
I'm
possible.
not either. So I was considering it. How does it make you aesthetic, by the way? Okay, you can keep your breasts full and you're less likely to have the abdominal thingy. I'm not sure it's enough. The truth is that, and that strength training that they keep on telling us, that we, even us, the providers, don't always remember to do, but every once in a while, we'll just feel guilty and we'll do it again. Whether or not you're using HRT, the truth is that as you are older, your muscle mass is reducing, right? And your metabolism is changing. It's not only women that are undergoing menopause, it happens to men as well. So if you're using HRT and you keep on having your hourglass figure, no middle age spread, your breasts are still nice and full, and you don't need the help of Victoria's Secret to keep your secrets, I would say either way, that strength training, those exercises, you still need for your own well-being, for your longevity, and for your old age well-being. Because evidence has shown that strength training prolongs life and helps you to live better in old age. So that a lot of us have moms and grandmas alive, but aches and pains in your 90s and stressed out, that's what they're telling us, that this is the time to prevent it. So I'll say I don't know the answer to that. I've never heard of it, but I'm saying that working from the basic principles, so even if you do, you'll still need that. And then I don't think it's worthwhile the risk of those cancers that we have said is rare. Medicine is all about the weighing benefits and risks. If vasomotor symptoms are about to kill you, why are you worried about a future ovarian cancer or a future whatever cancer, breast cancer, where vasomotor symptoms can kill you now? And vasomotor symptoms are even dangerous. I'm not sure. Maybe I don't know whether you stopped there, but nowadays there's a new thinking by menopausal societies that menopausal symptoms are not vasomotor symptoms, that's hot flashes, that they're not just benign things anymore, that they're predictors of cardiovascular health. So they are saying use HRT to prevent cardiovascular health when you have those symptoms, that it helps to protect your heart. So that would be a reason to use it, not because, I wanted to look good.
Yes. I think we might have taken all our questions because we are at the end. We usually want it to be just about 1.5 hours long. Thank you for being an amazing audience. Big thank you to our guest speaker again. We appreciate you. Thank you so much, Ma. God
Thank
bless
you.
you. We will come again.
My network has failed. I'm not even sure I heard anything now. But nice to see you, Temitope, and nice to see all the good work you're doing. Thank you,
Okay.
everyone.
Thank you, Ma.
Okay.
So a big thank you to those that joined us on YouTube. Please share the video. I'm sure it's going to make a difference to some women in your circle, to your spouse, to your children, or even your grandchildren. And it would also help our men to understand their women better. So thank you so much for joining us. I think Dr. Ijoma, are you ready for our group photo now?
What did you say? YouTube? We're on YouTube.
Yes, we're on YouTube live, Ma. Yes,
oh dear. So that many references to sex is now perpetuated for posterity on the internet. I thought it was a Zoom meeting and we'll be
Those conversations are very
You should have
important.
warned me. I would have comported better, spoken better English, and all that.
But it was spoken in the best possible context.
Thank you, Dr. Ijeoma.
So please, I would like you to turn your videos on so that we can take our picture for this week.
Our group photo.
Yeah. No, okay. I'm just still waiting for more videos to come on. More videos, please. Thank you.
See your beautiful faces.
Yes, it's good to see you. Beautiful, radiant.
Yes.
Thank you so much.
I see
Any
you.
more?
Prof. Omisoyo.
Yes, I can see more videos.
I see you, Fumilade. Hi.
Mommy, how you doing?
Hi,
Sister
well done,
Tony.
Professor Bello.
Thank you. Ivania had erudite scholarship listening to me. I think
Mommy,
I would have
hi,
comported a
mommy.
bit better.
At least we
Hi,
didn't have the 16-year-old, so we are good. We are good. Thank you. Thank you so much. I'm done with the pictures.
Thank you.
Okay.
Okay, so that is us done. Next week, we'll be talking about lifestyle health and aging. And it's going to be taken by a general practitioner with a special interest in lifestyle medicine. So that's going to be a very interesting topic for all of us. So we're looking forward to it. And that is going to be episode 10 of 13. Thank you so much for joining us. And so as we end, we'll just say our motto. We have a motto in the Link family. So you can unmute yourself if you have a quiet background and repeat after me. I live in love.
I live in love.
I stay in peace.
I stay in peace.
I shine my lights.
I shine my light.
I use my power.
I use my power.
So help me God.
So help me God.
Amen.
Amen.
Thank you so much,
Amen.
everybody.